malaria, it's tuberculosis can present in 9 degree. The investigations are routine blood examination, hemoglobin 9 gram percent, total count 3500, differential count neutrophil 64, lymphocyte 30, eosinophil 4 and monocyte 2, and the platelet are 10,000. MCV 75, MCS 23, MCSC 31. In the peripheral blood film smears, we show few microcyte, macrocyte with normocytes and no abnormals detected. Red T count 0.2%, PCV 30, ESR 64. The malaria antigens are negative, no mild parasite is found. Dengue, IgG negative. Fasting blood sugar 142. Postprandial blood sugar 187 and HbA1c 7.4. Renal function test is near but normal and the LDH is 356. Liver function test, bilirubin 0.9, total protein 6, albumin 3.8, globulin 2.2, AST 256, ALT 112, alkaline phosphatase 156. And the lipid triglyceride is high, 293, cholesterol 98, HDL 31, LDL 53, VLDL 8. Thyroid profile T368, T4 5.9 and TSH raised 6.17. VT 1 minute 40 seconds, CT 5 minute 10 seconds, PT is normal, INR 1, HBS antigen negative non-reactive, NTHCV non-reactive, CRP positive. Sputum for AB negative, MAN2 negative, urine albumin present, otherwise normal, stool for OBT negative, blood culture negative, urine culture negative. On ECG, the normal sinus rhythm is there. On X-ray, it's normal. On the USG, there is enlarged liver, size is 16.8 cm along the middle of the line with fatty changes. Spleen enlarged 13.5 cm, size, bilateral kidney size is normal, and portal vein diameter 10 mm, prostate 15 cm. We also consulted to our ENT surgeon for this hearing loss, and he have done the audiometry and says that it's bilateral sensory neural hearing loss of moderate. So we do MRI. And the MRI is within normal limit. So, what we do in the hospitalized patient, we give the injection ceftriaxone, 1 gram IBD, tablet beta histine, 16 mg TDS, 4 units of RDP, and symptomatic treatment. During the course of this hospitalization, his fever gradually decreased and he became defibrillar 7th. And his neurological symptoms are improved by the 9th or 10th day with the normal voice and hearing, and his gait become normal by the 10th day, and also weakness improved. So, this is the chart which shows how the progress is there. From the total leukocyte count, it's gradually improving. On the 15th day, it's normal, and the platelet from 10,000 to 1 lakh, it reaches to 15 day after 4 units of RDP. Fasting blood sugar and PLCS are well maintained, and at the discharge, it is in controllable limit. Serum urea, serum creatinine, and these are normal. And on the patient follow-up, his blood counts are now it's normal. Hemoglobin 11.2, TLC is 7,200, platelet 1,25,000, fasting blood sugar 106, post-blood blood sugar 136, serum urea creatinine is normal, sodium and potassium is normal. And in the follow-up also, the bilirubin, total protein, albumin, globulin, AST, alkaline phosphatase is normal, near but normal. Triglyceride is now normal, cholesterol, HDL, LDL, VLDL, but the TSH is slightly raised. Now it's also slightly raised. So we put our diagnosis: viral cellulitis and labyrinthitis with pancytopenia in a case of diabetes, hypothyroidism with alcohol liver disease.
Now the patient is normal.
Absolutely normal. But what is the cause? Most probably viral. Which virus? That we wanted to see. No, actually the patient had only 10,000 platelets and clinically patient has improved. That's why we didn't either the bone marrow or the CSF. That? Okay.
Next.
At the time we were thinking whether on the background of this patient, young patient, alcoholic, with pancytopenia, with cerebral involvement, whether this is a case of HIV. And we sent the blood samples and 2 rapid and 1 ELISA. It shows that it is a case of HIV reactive. I am coming. And we did the CD4 count at that time. It was 956 and CD8 was 2554. And we did the serology for this syphilis. It was non-reactive.
Serology for?
Syphilis. Now, I think 1 month back, we are following the patient. At present, it has come to CD4 count 757. So, our final diagnosis is acute vasculitis with labyrinthitis and pancytopenia in a case of HIV, diabetes mellitus, and hypothyroidism. And we have searched the literature.
Just spontaneous recovery after
I'm coming. So, in the literature, we have seen that there is a bilateral acranial nerve neuropathy in human immunodeficiency virus infection. So, actually, what had happened? Before coming to here, patient had a history of chronic alcoholic, and he had an intermittent pain abdomen, particularly in the epigastrium. And he went to the reputed hospital, reputed nursing home, and where the physician did the upper GI endoscopy. Before that, he did the HIV. HIV was negative, and it showed that it is a case of duodenitis. Along with, he was first time diagnosed as a case of diabetes mellitus and hypothyroidism.
how many months before?
3 to 3.5 months back.
So acute viral.
And this is a case of acute viremic stage and involving.
Induced because of this gynecoscopic intervention.
It is very difficult to say where from the infection has come, that we don't know. But it was a proved case that before that endoscopy they have did the HIV and it was negative. And so most probably it is a acute viremic stage causing the bone marrow depression and also the neurological manifestation, and neurological manifestation is
even in acute viremia, all this.
absolutely correct.
Is it may not require bone marrow depression, may not be there.
No, but because here in our case it is a reticulocyte count is only 0.2%.
Viremia may not be.
Absolutely, but reticulocyte count
I
is
think
only
it is
0.2%.
unusual. Acute HIV infection.
Yes, sir.
What is happening with pancytopenia? And this sort of things, I think it's not very usual presentation.
It is not usual.
We are well aware of the presentations of acute HIV.
Absolutely.
But this sort of HIV disease has gone into systemic. If you look at Harrison's textbook, even pulmonary thromboembolism, pulmonary hypertension HIV, thrombocytopenia HIV, that is well known.
Absolutely.
But this sort of it is somewhat very, very atypical, I think. But I think you have definitely sussed out the cause of that. Most likely now patients improve with treatment. Most likely it is
Without any doubt, because
but I think it's very, very difficult to suspect in this case.
Still no ART has been
Yes.
given. CD4 is not known.
Yes.
CD4
That's why Dr. Daga is telling
It is
that.
acute viremia.
It is a case of acute viremia. At present, patient is asymptomatic total.
They don't require any.
At present.
Can I make some of the comments about the case? One thing that if this MRI is normal, how you are too sure about the diagnosis of cerebellitis with labyrinth? It is only the clinical.
It's a clinical matter.
But there is no evidence of
No
MRI.
evidence.
Yes, first thing. Second thing is that why you are not thinking a case of a systemic immune response syndrome in this patient, which may occur even without ART therapy in a patient of HIV. It doesn't matter. It is only the acute viremia producing so many organ dysfunction, and that has abruptly improved without your any treatment. That is due to acute viremia of HIV. It's very, very difficult to solve. I think you should consider systemic reconstitution syndrome or SIRS syndrome, which can happen even without treatment of a patient having a natural history of this HIV disease. So that is one of the very, very important differential diagnosis. Except I agree that your one differential diagnosis should be acute HIV, but the very common and very usual, close differential diagnosis is SRIS.
But SRIS occurs particularly after after the starting of the heart
But
attack.
there are very, very much number of literature that is showing that even without treatment with ART, patient can have a SIDS syndrome without even any because your liver enzyme is increased, your CNS is increased.
Liver enzyme is increased, most probably it is due to alcoholic hepatitis.
No, what I am telling
Why I am
that
telling
there are
because
so
there
many
is
things
more.
are there, so many things, so many organs, and that has improved rapidly without treatment. Then only virus, HIV virus is done is very, very difficult to solve. That's my point of contention in this
I think
patient.
about immune reconstitution syndrome, I think what was CD4 count? It was absolutely normal.
It was normal, all true.
There should be some variation in immune reconstitution syndrome. You should have some sort of aberrations in terms of particularly CD4. Because as there is immune reconstitution, CD4 will be definitely up. It will be initially down.
Initially down, followed by it will be up,
Yes.
then there will be the
That was not present in this case.
No. Because nobody has done this CD4, because nobody has thought in that line.
2 points I would
I
like.
have told CSF we have not done because it is only 10,000. The patient was improving. That's why we have not done.
2 points. One is liver. Liver disorder you cannot explain in the terms of HIV infection as because SGPT, SGOT.
I have told it is a alcoholic.
One thing that is and Professor Mojumdar rightly pointed out that it is not a common presentation of HIV encephalopathy or CNS manifestation in HIV disease.
This is a very rare
Because
manifestation.
cerebellitis with labyrinthitis is not usual. It is usual in a case of other, that means echo virus, arbovirus, it is usual phenomenon. So CD4 count is normal, that's why it is unusual other infection. Super.
That's why you have shown the paper also that there was reported case of labyrinthitis and along with
Not
this.
cerebellitis.
Sir, can you go for this Coxsackie, echo and other
Yes.
virus study?
Other virus
This
study.
patient, even with normal
Patient
CD4
clinically,
count.
sir, improved after 10 days.
Right.
Then the at present
Antibiotic.
patient is okay, but most important is that per year viral CD4 count is decreasing more than 100. That means it is a rapidly progressing. Usually it
In
occurs
case-
below less than
Steroid
In case
No, we have not used steroid.
Nothing.
Nothing.
No,
No,
in case
no,
of
it was-
normal count, in case of normal count, other virus infection may occur. That's
Might be, but not the opportunistic infection.
No.
Thank you.
Thank you.
It is reversible.
So let us go to the third case, the case of postpartum